Dr. Rawat for joining a clinical meeting. So thank you so very much. You know, I think it kind of enhances the quality of the clinical meetings when we have a meetup of the state pulmonologists and pulmonologists from outside the state. So I think it adds to the knowledge sharing. So we had this for last month as well and for this month as well. So thank you, Dr. Rawat, for joining with us today and for giving us your hour-long of evening time. I will not thank the rest of my friends who are here with who've joined today and logged in, because as we say, we are all in the same boat, brother. So thank you all, and over to Dr. Amita as well to flag off the session, and then the session will be taken up by a moderator, Dr. Shomik Basu, who will be introducing the experts. So over to you, Dr. Amita, for a short, quick word.
Yeah, thank you, Devjanidhi. Very good evening to all of you. Welcome you all. I will just start with the introductions. I think the very senior most, Dr. Shantanu Bhakta, he needs no introduction to our Kolkata viewers. He is a very senior pediatrician, and we are blessed to have him with us today in the panel as an expert. And to introduce Dr. Rawat, he is the director of Childcare Hospital Indore, and of course he's the secretary of the IIP National Respiratory Chapter in 21-22, and his areas of interest are pulmonology, infectious disease, and vaccinology. We have the presenter with us today who has very kindly consented to being with us. That is Dr. Shubhashish Saha. He's the pediatric surgeon par excellence in Kolkata. He's an MS, MCH, and DNB. And a chairman of the Secretary of Chairman-elect Society of Pediatric Urology. He's the past honorary secretary of the Pediatric Surgery Association of West Bengal. He's the past EC member of the IAPS and the editorial secretary of the Journal of the Indian Association of Pediatric Surgeons. And last but not the least, the moderator of the session, Dr. Shomik Basu. I think he also needs no introduction to the Kolkata viewers, the pediatricians. He's a very dynamic speaker. He's often found speaking at so many forums, and he's also the treasurer of the West Bengal Pediatric Pulmonology Chapter. He's also an active member of the Medical Legal Chapter of the IAP. So I think without much further ado, we can start with the sessions. Shomik, can you start sharing your slides?
Before Shomik starts, I just want to add just one liner to this wonderful introduction that's been given by Dr. Amita. The USP of our monthly clinical respiratory meetings are they are single themed. So it adds to, if you would note, this one theme with a lot of experts talking on it. So there's a lot of knowledge sharing. So with that, I would hand over the microphone to Dr. Shomik.
Good evening. Thank you for the kind introduction. Since Amita has already introduced this renowned speakers, I'll just go through them. We have Dr. Shantanu Bhakta, one of the senior most members of our respiratory group. He's a pioneer in the Eastern region for one of the first persons to introduce pediatric pulmonology in Kolkata. We have our favorite and our beloved Dr. Sanjay Singh Rawat, who is the secretary of the National Respiratory Chapter, a very active member and a very sincere person. I hope he is not being bored because he is very strict about timing. So next we have the pioneer of all pediatric surgeries. He doesn't leave anything in pediatric surgery right now, but he's a specialist in pediatric urology, I must say. I have a good connection with him for last 10 years. So he specializes in almost all types of surgery, specialized surgeries in pediatrics. So mainly I would thank Shubhashish Da because most of the slides are made by him. I have just added and subtracted little bits of it. Without wasting any time, we'll go to the first question, which will be directed to Dr. Rawat and Dr. Shantanu. So Shantanu, the commonest complaint of the airways, congenital airways, is actually inspiratory stridor in a newborn. So, and we diagnose, and the pediatricians easily diagnose them as a case of laryngomalacia. So what are the common presentations of laryngomalacia in newborns?
Okay, thank you, Dr. Saha
Okay.
and Dr. Basu, Dr. Subhashi, and all the office bearers of IIP Respiratory Chapter West Bengal. Thank you very much for asking me to join and knowledge sharing for this very important and very popular session run by IIP and RC West Bengal. So we start with this case and the common presentation of laryngomalacia. As you all know, this is a very common anomaly seen in infants. Commonly, these infants they present with a sort of wet type of stridor, inspiratory stridor, usually by 2 to 4 weeks of life. So this time of presentation is very important because a infant will never present right at birth with the stridor of laryngomalacia. So typically, the symptoms are going to appear by about 2 to 4 weeks. Then typically the symptoms they are more with respiratory infections. Then they are more when the baby is lying supine. It gets less when they are prone. Then in case of mild to moderate laryngomalacia, the stridor is less while he is crying. It is more while he is feeding or sleeping. And along with that, there could be some other symptom like in case if the laryngomalacia is very severe, you could have things like sleep disorder, breathing, or difficulty in feeding or swallowing, or even symptoms of GRD. As because study says that almost 60% of children with severe laryngomalacia they can have GRD, and about 50% of them they can have a sleep disorder breathing. So these children they have a lot of difficulty in feeding and swallowing, and they can present with failure to thrive, can even apneic spell. So the spectrum depends upon the severity. It could be very mild, just and intermittent inspiratory stridor to very severe symptoms which are leading to feeding difficulties, apnea, sinuses, and failure to thrive.
Thank you, sir. Shantanu, how do you diagnose clinically, and do we suggest any investigations for laryngomalacia?
See, to start with, diagnose by the inspiratory stridor, as we have already told, which starts by 2 weeks and goes to the peak by 6 months of age, and also by crying, agitation, any type of agitation, that is crying, feeding, like that, it increases. And mostly it is clinically diagnosed. And if any investigation is needed, it is a flexible laryngoscopy that will find out what is there.
Okay. So, Shantanu, how do you counsel parents? Because parents are very worried about the abnormal sound, whether it is going because it increases in illnesses, increases in exertion. So how do you counsel the patient, and what do you tell them actually?
Yeah, that's very important, because parents often complain that there is a ghor shabda, shordi boshe ache. There is some respiratory congestion is going on, what they feel, but it is actually the sound. And expectant observation, just tell them that it will go away as the laryngeal tone increases and all. So there is it is a conservative management that we take care of.
So the take-home message for pediatricians will be diagnose properly, especially the supine prone position, and counsel the patients and tell the patient, as Dr. Rawat said, it actually comes within 2 to 4 weeks and months, yes, but it disappears. It also disappears between after 2 years of life. So take the tell the red flag signs to the parents and tell them and counsel them to at least wait for 2 years of life. Subhash is the how does tracheomalacia present, and whether can they both exist together?
Good evening, everyone. First of all, my greetings to all the members and panelists. Now, tracheomalacia, as we know, laryngomalacia is quite more common than tracheomalacia, but what we observe is often in babies with esophageal atresia, we find a percentage of them, maybe around 10% of 10 to 12% of babies whom we operate for tracheoesophageal fistula and esophageal atresia, they land up with tracheomalacia. So in that case, even in those cases, what we find is, how do we diagnose? Now, especially that particular sound, expiratory stridor, everything is there, but how do we first diagnose? Because it's a frothing at birth, then we take for the elective ventilation, then we do the surgery. And after that, we go for elective ventilation for usually 24 hours. And after that, when we extubate, the baby is absolutely fine on ventilator. But the moment we extubate, the child cannot maintain saturation and starts this expiratory stridor is there, the peculiar sound, and particularly on feeding, it gets exacerbated. So that's the classical presentation. Now, different means what we do is there are certain special maneuvers, like we can give CPAP and all these things sometimes help in tiding over this crisis. But if the things are severe, recently we had a baby who was, in fact, it was diagnosed by Paul he did a bronchoscopy, and we found classically that it was not only a tracheomalacia, it was a tracheobronchomalacia. So there was a collapse of one of the lungs along with it. So this baby needed a tracheostomy, but it's a one-off thing, and it's not usual that we need a tracheostomy to tide over.
So surgery is not needed very commonly, only in severe cases.
Once in a while. Yeah.
Okay, thank you.
One question can I ask to Subhashish?
Yeah.
Usually they say in upper air obstruction, tracheostomy should be done judiciously or not at all. Yeah. Is that okay? Is that correct?
Yeah. Especially in this particular baby, we had a bronchomalacia along with it. Yeah. So, and one small tip, that is, in a flexible bronchoscopy, sometimes this bronchomalacia and tracheomalacia part is little overdiagnosed. Sometimes. So that's another point of it. And so what we did was, we did elective ventilation for a couple of weeks, for 3 to 4 weeks. By the time bronchomalacia improved, and then we went for tracheostomy to tide over the tracheomalacia part. And even now the baby is off tracheostomy.
We have similar cases with us next slides. So we'll stop this slide over here and we'll go to the next case. So
Dr. Basu, I'd like to just say one point regarding laryngoalacia is that we often paint it as a benign condition, but I think it is the job of pediatrician and pulmonologist to be very cautious of labeling a laryngomalacia a benign condition, because some severely affected children, they can have lot of symptoms in form of apneic episodes and cyanosis, and even a severe GR, sleep disorder, breathing, feeding difficulty, failure to thrive. So these are the children who have to be followed more closely, and they might require surgery in form of supraglotoplasty. So I think let us not paint laryngomalacia as absolutely benign. Almost 3/4 of them they would be fine, but at least 1/4 of them they might require close follow-up and workup and even surgery.
Yeah, true.
Apneic spells and all. Yeah. Cyanotic spell.
Okay, so we go to the next slide. So a 22-year-old male neonate, these are all real cases, not my original cases, but these are cases collected. This is actually a case from Bardhaman, which has been reported from the Bardhaman Medical College. So 22-year-old male neonate from a village was referred to pediatric emergency ward for respiratory difficulty for last 1 week. Examination of respiratory system revealed less movement of the left upper chest, trachea was shifted to the right, vocal resonance was decreased in the left side, and on auscultation, diminished breath sounds was found on the left side. So there was some problem with the left side. So we did an X-ray. Shantanu, could you explain the X-ray for us, please?
The X-ray shows that there is a hyperlucency of the lung, and something is pushing the mediastinum to the right side, and there is a limited aeration on the left side of the chest. That much we can see. There is hyperaeration of the
absolutely.
So radiolucent lung with mediastinal shift to the right.
So there is hyperinflation of lung, and there is probably increased pressure on the left side of the lung, which is shifting the mediastinal to the right. Right. Okay. So what do we do next, Shantanu, in such case?
All these cases in congenital lung lesions, we have to go for the CT and MRI. Here we can go for CT.
Now we have done a CT scan of the same patient and we see such picture. What do you suggest?
Now, there is something which has pushed the mediastinum to the right, and what we can find out there is that the lobe is increased. I mean, it's a case of congenital lobar emphysema.
So, Dr. Rawat, what do we do next?
Okay, I think first of all, let us see the term whatever we are using, like congenital lobar emphysema. This term again is a misnomer because currently the term which is used is congenital alveolar hyperdistension or hyperinflation. Because on histopathology there is not much emphysematous changes. There is no destruction of the interalveolar septa. So this term congenital emphysema is probably a misnomer, and we should use the word as congenital lobar hyperinflation or hyperdistension. So once you have diagnosed the child as symptomatic child with hyperinflation of one particular lobe with herniation on the other side, usually these children they require surgical correction and they require lobectomy because they are not amenable to medical management, and medical management is going to be futile. So these children should be taken for early surgery, and once they undergo lobectomy of that particular affected lobe, there is almost a complete recovery. The remaining part of the lung, it compensates, and the child absolutely has got a normal life. But I'd like to add a caveat. Children with congenital alveolar hyperdistension, 25% of them, they are symptomatic at birth, about 50% at about 1 month, and 100% by 6 months. Rarely they can be asymptomatic. So this is absolutely different from other anomalies. Is that in other anomalies which are asymptomatic, you always try to go for surgery. Whereas in CLE, if child is asymptomatic, you can leave it alone, then the child will not have problem and you may not go for surgery. So a child who has been detected with CLE on an routine X-ray or an accidentally detected on X-ray, you may not go for surgical correction. You may leave it alone because these children are not going to have any problem in the later life, and they can lead a normal life. So this is the very important difference between other anomalies and anomalies, is that if child is asymptomatic and other things like sequestration or CPAM, you have to operate them even if they are asymptomatic. Whereas in CLE, you can leave it alone and you may not operate it.
So this is one congenital lung condition, which is if the child is asymptomatic and there is no mediational shift or compression effects, we can leave the child alone, but always advise the patients to come up or at a regular follow-up.
Yes. Shamik, there is the algorithm like less than 2 months and more than 2 months. So, and in this, yes, and the investigate.
So Shantunanda, if we have time, we'll discuss that later.
Okay.
Let us cover the cases. So Subhashis, if we need surgery, we'll do a complete lobectomy. That's all, na?
Yeah, we'll do a lobectomy. There are some centers in the world who go for thoracoscopic lobectomy. But in CLE, we have not done thoracoscopic lobectomy as yet, because there are some technical issues. So we do an open lobectomy, and it's very important to know that up to 6 to 7 years, up to 8 years actually, the lung continues to grow.
Yes, absolutely.
So any lobectomy done at a young age, the other lobes completely compensate, 100% compensate.
This is this is one condition which has a very high good prognostic value.
Yeah.
So
that's it.
Recovery rate is very high. Yeah. So we go to the next case fast. So this is also an original case. This is
Shamik, let me, I'm just interrupting for a second. There are 2 questions, one from my side. Let us take the questions, otherwise they are very short questions and
so Subhashis, you take the questions and direct it to the panelists.
2 simple questions. What are the indications for investigation in a child suffering from laryngomalacia? Which children should be investigated? A child who is suffering from laryngomalacia. This is from myself, and there is a question from Debjani also. When would you want to intervene in a case of laryngomalacia?
So
I think, Dr. Raj, carry on.
Dr. Bandhur, please.
Yeah. So in case of laryngomalacia, when it is severe enough to have the cyanotic spells like bradycardia, cyanosis, apnea, in those cases we have to investigate. That is what we do, the laryngoscopy, flexible laryngoscopy. And in those cases, we have to
Is it
intervene.
laryngoscopy or bronchoscopy? Because in that case, you can see the lower respiratory tract also if you do a bronchoscopy.
Most of the cases of laryngomalacia, there are always almost always there are other airway abnormalities. So we go for the whole lung bronchoscopy. In that case, you can say bronchoscopy, but initially it is a flexible laryngoscopy what has been written there.
Okay. Okay. And what are the indications for intervention in case of laryngomalacia?
Same.
When will you go for a surgery?
Same, when it is very severe enough for the life, that is autopexy or bronchopexy. Dr. Subhashi, is it okay?
Yeah, I mean, I also have given a picture, I think it's later on. I mean, how autopexy helps in very severe cases. Actually, in which cases you have to intervene, the answer is the child is not gaining weight, the child is repeatedly sick, and acute life-threatening events are there, and it's being repeated. So in these cases, you can never wait. You should not wait, because there are issues with cerebral hypoxia and other brain maybe affected. So you have to go straight to, and autopexy is actually, it seems, looks like a very great surgery, but it's actually a very simple surgery. And I have given a picture which clearly shows how it affects and how it completely, because aorta stays in front of the trachea. It compresses the trachea. And actually, the basic, we need to know the basic pathogenesis of tracheomalacia and laryngomalacia. Now, trachea is not a complete ring. So there is anteriorly, it is cartilage, almost 4/5 of trachea is cartilage anteriorly, and posteriorly 1/5 is membrane. Now, in case, if that membranous portion is less, if it is a complete, it doesn't collapse. And if the membranous portion is more, rather, so it completely collapses. So here, if you just stitch the aorta to the sternum, behind the posterior surface of the sternum, it holds the trachea apart. So that's the basic theory.
Okay.
Oh, so the aorta cannot compress the trachea.
Yeah,
okay.
Exactly.
And Shami, can you go back to the X-ray in the previous slide? In the congenital lobar overinflation. Yeah, if I say this is an X-ray of pneumothorax, why you are saying this is congenital lobar overinflation? If I say this is a CT and X-ray of a pneumothorax, what is the differentiating point between these two?
See, there is a radiolucent.
Bronchoscopy lung markings are there.
See, there is a radiolucent area here.
No.
Subhash, can I show you this?
Yeah, please.
Yeah, can I show this? This radiolucent area is there, which is pushing the mediastinum that side.
Radiolucent area will be in the pneumothorax also.
No, it has got bronchovascular markings.
Yes, Dr. Rawat has said, there are bronchovascular markings are there.
Pneumothorax won't.
And I
there is
think
no
this is
collapsed lung.
This is a very
also you will get the collapsed lung. I think
this is a very pertinent question, I would say, because we had patients referred from outside
and
where it was
the
thought
domes
to
of
be a
the diaphragm
pneumothorax and the drain was inserted by someone. So I mean, if you have to be very, very careful. Just look at the bronchovascular markings, and if the X-ray is overexposed, you try to. I mean, you have to counsel.
Look for three signs: bronchovascular markings, a collapsed lung, and the diaphragm also on that side.
Yeah.
Okay. So let us proceed. So this is also an interesting case. 18-year-old boy with exertional chest pain, dyspnea during sleep. Remember, this is an 18-year-old boy. He gave a history of antitubercular therapy taken around 3 months. On examination, there is mild scoliosis, the left side and drooping of the left shoulder. Chest expansion was asymmetrical with reduced expansion on the left side. On palpation, apex beat shifted to the left side, trachea was shifted to the left side, and brachial femidus was increased. On percussion, the note was resonant over the left precordial region and dull in the left axillary region. On auscultation, bronchial breathing was heard over the left lung in the axillary and infrascapular region. Now we get an X-ray like this. So, Dr. Rawat, what do you suspect? This is a strange looking X-ray. So, what do you suspect in an 18-year-old boy who has survived without any problems till 18 years of age?
So I think seeing his entire clinical picture in form of mild scoliosis, left side drooping, left shoulder. So all these, there are skeletal changes also there indicating that this is a chronic lesion. And seeing the X-ray with the almost shift of the mediastinum towards the left side with an hyper expansion of the right side of the lung almost relating to the left side, there has to be some chronic collapse or agenesis of the left side of the lung, which has led to compensatory hyperinflation of the right lung, and almost looking like herniation. So either it has to be some chronic, because he had a history of antitubercular therapy. So it could be some chronic collapse of the left lung, which has not been treated, left and neglected, or even agenesis.
So what do you suggest next?
A CT scan.
Okay. So now a CT scan was done. The A is the non-contrast and B is the contrast. So Shantanuda, could you explain the CT scan?
I'm very poor in explaining the scans, but still I'm trying. There is no lung tissues in there inside, and here the bronchovascular markings can be seen by the contrast. So there are some loss of the lung volume, which indicates towards the lung hypoplasia.
Can you speak loudly, sir? You're not audible.
Am I audible now?
Yes, sir, better.
Okay.
Yes, sir.
Yes, sir. Please go ahead.
Okay. So in the left side, there we cannot see any lung tissue as such there, which is being seen in the right side. So there is some loss of lung volume in the X-ray also.
Absolutely.
It can be seen.
Very well explained. So if you see the contrast and the non-contrast, there is actually no lung shadow on the left side. So there must be. So what is the diagnosis?
Hypoplasia. But then,
Okay.
just a minute, previous X-ray. Now, what Dr. Rawat was telling, there is a lobar collapse, because it may be because the mediastinum is shifted that side. Unless the scan is being done, we cannot say this is, by seeing the chest X-ray only, that there is a lung hypoplasia. Is that okay?
That is what we are trying to convey the message in this. We'll give a take-home message that when you die, when you suspect congenital lung problem, so always do not rely on the X-ray at all. The CT scan is the gold standard sometimes. So, so what, Dr. Rawat, what is the difference between why are we worried about what is the difference between hypoplasia, aplasia, and agenesis?
You see, if it is a hypoplasia or aplasia, there is some amount of redundant lung tissues there. So that is a potential source of infection where it can lead to recurrent contractive problem. So if it is something like hypoplasia, it might require surgical treatment in case of the child is presenting with recurrent respiratory infection. Whereas in agenesis, since the lung is totally absent and there are no redundant airways, so you don't have to worry. So in case of hypoplasia, because there is some redundant lung tissue, there is chances of recurrent infections there. So that's why a CT scan is very important to differentiate between these three terms.
Sir, if we get a case of total aplasia, which procedure should we avoid?
Bronchoscopy.
If we get a case of total aplasia of the lung, which procedure should be better be avoided, and why?
It is bronchoscopy. Can you?
Why?
Because it can damage the rudimentary bronchus that is there in aplasia.
Because in aplasia, actually, everything stops at the carina. There is nothing beyond the carina. So if you go on bronchoscopy, you might the bronchial cramp, or you might injure the carina.
Yeah.
Okay. So the learning points is unilateral pulmonary hyperplasia can present in late adolescence. So it can go undiagnosed before the period of adolescence, and the totally shifted mediastinum with congested ribs and absence of breath sound on the affected site, he gives a hint towards the condition upon clinical examination. So Subhashis, that these should be managed as soon as possible, is it?
Dr. Shah.
Yeah, sorry, I'm muted. Managed means, if there is no, if there is complete agenesis of lung, there is no issues.
And remember, there is both agenesis of both lungs is not compatible for life. So
yeah,
we are only worried about agenesis of one lung. So we go into the next case. Subhashis, this is for Subhashis. This is a surgical case. So if you get
Soumik, can I come in for a second, please?
Yes.
Yeah, one thing I just wanted to say that I think that is a wrong message going on out that bronchoscopy will damage the lung. So we have done umpteen number of cases, and I have a series of 3 cases where it was lung aplasia and agenesis. So, you know, the bronchoscopy will determine that whether there is aplasia or agenesis. If you see the bronchus, you know that the lung is, there is a rudimentary bronchus. Otherwise, when you go from the carina, it goes on to one side. Usually it's the right side that is seen, and you don't see the other side at all. So you diagnose that, okay, the other side has not developed. So it is a very good way of diagnosing. And other than that, you can also get some lavage and you can do it. So it's such a thin tube that there is no chance of damaging.
Subhashish Shah, Subhashish, that you get an X-ray like this in a typical newborn, what do you suspect and what lung anomalies may be associated with it?
Lung anomalies, actually, this is esophageal atresia, as the tube is coiling in the esophagus.
What we were talking about earlier.
In the pharynx. So the difference between the two sides is on the right side, there is completely gasless abdomen. So we are expecting a completely separate, I mean, pure esophageal atresia. There is no tracheoesophageal fistula. And on the left side, this one, on the other side, there is a gas in the abdomen. So there is a distal tracheoesophageal fistula. Now, in these cases, nowadays we always do a bronchoscopy before we treat the tracheoesophageal fistula, because there are 2 advantages. One is, in rare cases, we have multiple fistulas. That's a fistula in the upper pouch as well as the lower pouch. That can be diagnosed beforehand. Otherwise, it's very difficult during surgery. Number 2 is, we know the exact site of the fistula. That also helps us during surgery. And because nowadays, often we do a thoracoscopic repair of tracheoesophageal fistula. So if we get a classical total roadmap, then it is helpful. Now, as I was telling you previously, now many of these cases, rather some of these cases are associated with tracheomalacia. So during bronchoscopy, we also get to know whether we are expecting a tracheomalacia and delayed extubation. So accordingly, we can counsel the children.
Absolutely.
But generally, we are expecting some heart defects, cardiological defects, not usually any lung defects.
So the purpose of putting the X-ray is the absence and presence of stomach gas in such cases. So for postgraduates and for clinicians who read a little, so it's very important. That is what Subhashish said. See, there is a complete gas absence of gas shadow and there is a gas shadow. In both the tubes, the Ryle's tube is not good. So the Subhashish's case is, this is Subhashish's own case. So we'll put the history first. So newborn with history of maternal hydramnios, oral frothing since birth, diagnosed as pure esophageal atresia, underwent cervical esophagostomy and Mickey button gastrostomy, perfectly well on ventilator, what we are talking about, but they were at severe respiratory distress on attempts of extubation with collapse of right lobe. So Dr. Rawat, how to proceed?
Now, since this is a child who has been operated for esophageal atresia and esophageal fistula, and there is distress on attempt for extubation with collapse of right lobe, so there could be some mucus plug obstructing the right lobe, or even some airway anomaly. So I think the ideal thing that if the child doesn't respond to conservative management like a good chest physiotherapy and nebulization with saline, I think this is the right child for bronchoscopy, where you actually peep into the bronchus, and in case if there is some obstruction, you remove it. And if it is something like bronchomalacia or tracheomalacia, then probably you would require a longer period of ventilation. And usually they might get all right with some time passing by. And most of them would not require any surgical intervention, and most of them they're going to come out. But rare case, if the child is not being able to extubate it, probably you might even require surgical intervention.
Okay, Shantanu, you agree with all these points? Okay. So Subhashish, you take on this slide. So there was tracheomalacia, increased collapsibility of EA. So how do you proceed in such case? Now we know that the child has severe tracheomalacia. Then how do you proceed in this case?
As everyone, all the panelists have said, that the basic treatment is conservative treatment. So you may give some main is prone position. Then you have to parallelly treat the GERD. You can give some positive airway pressure. Usually we can tide over milder cases with these things. And of course, you have to treat the infections. Nowadays, there are some silastic stents available which can be put across the trachea to tide over the crisis. And basic thing is, now you can, if you go to the next slide, there is a aortopexy picture is there.
Hey, I have removed the slide. I'll come back to that later. Okay. After we complete, I'll show that slide.
Yeah. So as I have already told you, the basic thing is if conservative treatment fails, then temporary tracheostomy can be done. So that reduces the that makes it more stable. That because at the area of tracheostomy it is held up. The trachea is held up in the with the skin. So it causes some opening up of the tracheostomy tube causes opening up of the trachea, a collapsed trachea. And with age, with time, maybe within 3 to 4 months, it becomes more stable. Trachea becomes more stable, and the symptoms of tracheomalacia reduces, and the child can be weaned off tracheostomy.
Shubhashish, it's a complication of stents.
Stents we have not used ever, so I have no idea.
Okay, thank you.
Because at Bangalore, one of my friends have used, but I'm not sure. I have not used it.
Acha, Shantanu-da, a 10-month, we go to the next case. A 10-month-old male comes to the emergency department with wheezing and coughing for 1 day. Patient had similar coughing and wheezing episodes in the past. On examination, he seems to be in respiratory distress with audible wheezes, chest retraction, expiratory rhonchi and crackling. As usual, he was given salbutamol nebulization with improvements of symptoms. Respiratory rate decreases, aeration improves. He also had a history of recurrent episodes of wheezing and cough with respiratory distress, for which he has been hospitalized for 1 to 3-4 months of age. So primarily, what do you think this case may be?
This case, 10-month-old though, is having recurrent episodes of cough and wheeze for which he was admitted. That is number 1. Number 2 is having fever and also coughing and wheezing. So some infective etiology might be there.
Abdullah sir, please speak loudly. You're not audible at all.
Yeah. Now it is audible. Hello.
Yes, sir. Yes, sir. It's audible now.
Okay. So
is there any background humming noise? Can anybody hear?
I am aged. My laptop is also aged. So there is a fever, there is a cough, wheeze, and there is a recurrence of this wheeze and cough. So we are thinking in terms of reactive airway disease by taking history of the family history and all these things. At this point of time, we cannot say anything very particular. So we'll go for a chest X-ray.
So, Dr. Rawat, similar feelings?
Because there is audible wheezes and retraction also.
Okay, now we do the chest X-ray. Now you have a chest X-ray, Shantanu-da. What do you see?
Yes, there is in this X-ray AP view, there is a hyperlucency of the left lung with little hyperaeration, and nothing much can be seen now. I'll go for it. The lateral one, have we done? Yes. Here you can see there is see the trachea is there, which is pushed in front, and there is a big mass type. Okay. So show me, you said. So there is a big something is there in front, behind the trachea and in front of the esophagus. So there is a mass-like lesion which is there in the lateral X-ray. We can see.
So Dr. Rawat, what do you suspect?
Seeing this picture of hyperinflation of the upper lobe and of the on the left side, with probably I can see a collapse of the left low lobe getting pressed. So I think this mass it could be anything like a bronchogenic cyst or a sequestration. So I think we must do a CT scan to delineate this mass, because this is a mass which is pressing over the airway, causing hyperinflation. So it could be something like a sequestration or even a bronchogenic cyst.
So our catch-home message is, if you suspect something which you cannot purely diagnose by X-ray, which looks sinister, so always go for a CT scan chest. So here barium esophagus was done. This is Shantanu Bhakta's own case. Okay. So Shantanu, why did you do a barium esophagus?
This is a very old case. This is a very old case. That time I felt like doing a barium esophagus, whether there is any shots of displacement in the esophagus. And in AP view, I found that the esophagus was displaced laterally, as seen in the AP view. And in the lateral view, it's coming out very nicely that there is a trachea and there is a esophagus. There is something there, and which is a mass, which is, that means it is a central mass like. That much we can say in this barium esophagus. So and now the CT scan can be done.
In the present age, would you go for a barium esophagus?
I don't think so.
Okay, thank you. So now you have a CT scan done, and there you can see this line. Shantanu, please explain.
So this is the mass which is sitting in front of the vertebra behind the larynx, which is a slit-like, and there is a left bronchus which is also pressed, and esophagus is pushed laterally. So this is the big mass in central area, shows like bronchogenic cyst.
So Shantanu, how is bronchogenic cyst different from other lung lesions?
Bronchogenic cyst, actually it arises from the tracheal diverticula in the gestational period. And what is your question like? How is it differs?
From the other from the other congenital pulmonary lung lesions.
Achha. So this is a lesion, this is a mass lesion. It does not have any anything to do with the gas exchange or anything like that. Is it okay?
Yes. So this is a pure cyst. It develops later in the embryonic life.
It's a mass lesion.
Yes,
like.
Yeah, mass lesion. So Subhash, what do you do with it?
No, actually,
Shramik, I have a question before going to Subhashish Saha.
Yeah.
Why the lung volume of the left side is much less than the right side? It's almost half, less than the half. I am asking you or anyone, any of the panelists can answer, because the right lung is much larger in comparison to the left lung.
No, Subhashish, what it may be that this is done in different cuts, no?
So do you have a, and also in this X-ray, I have a question. As we do the lateral X-ray of the chest, in the lower vertebral part, there will be gradual darkening because more air will be here in the lower vertebral part in the lateral X-ray. But here, some opacity, it looks like there is an opacity in the lower part of the lung. Yeah.
Here.
Yeah. Yes, absolutely.
This is.
So
I can't say.
That is a portion of the lower lobe, left lower lobe. So in case if there is a collapse of left lower lobe, then you'll get an opacity here.
So probably there is a collapse of the left lower lobe. That's why the left volume of the left lung is also less than the right lung in the CT category.
Any other questions?
No, I think a very common differential diagnosis in such a history, if there is such a history, I would consider along with bronchial cyst, it could be esophageal duplication cyst. We have found a couple of esophageal duplication cysts exactly at this location. And only during surgery, we discovered that it's arising from the esophagus.
So Subhash, we cannot differentiate before surgery?
Not really. Because most of the esophageal duplication cysts do not communicate with the lumen of the esophagus. So even if we do it nowadays, barium is not done. We do a contrast CT scan, oral and IV contrast. But often it is similar, exactly similar. So there's a compression on the esophagus, and on table we discovered that.
So Subhash, what will be your approach in that case?
Approach is we can do it thoracoscopically, because mediastinal lesions nowadays we do thoracoscopically, or you can just do a posterolateral thoracotomy from the here. It will be better if we approach from the right side. The dictum is in the upper third and middle third, lower third. It's better to be approached from the right side, and middle third approach
And
from the
upper.
right side.
Okay.
So we'll go to the next case. So neonate presented with respiratory distress after birth, stabilized on ventilator, chest X-ray was done. This is a clear-cut X-ray. I'll just ask Dr. Rawat to say the diagnosis and go as soon as possible. So Dr. Rawat, what do you see and what do we suspect?
Now this is a right-sided diaphragmatic hernia, which is very unusual because
Yes.
the diaphragmatic hernia is more common on the left side, where this child is showing a right-sided hernia. Because 80% of hernia on the left side and right side hernia are indicating of a more serious disorder and a more likely risk of complications.
Yes. Do they have more congenital anomalies associated with?
Yes, the right-sided hernia, they have got more congenital anomalies. They have got a more severe course and more stomy, lot of lung hyperplasia, pulmonary hypertension, and they have got a poor prognosis as compared to those on left side.
Okay. So Dr. Rawat, suppose you have got this case. So do you immediately give a surgical referral?
Absolutely no, because these children, when they are born, they have got quite severe amount of lung hyperplasia. They've got severe pulmonary hypertension. They are acidotic, hypoxic. So if you don't correct their hypoxia, pulmonary hypertension, hemodynamic hypertension, they are at a very high surgical risk. So it is very important that these children, they are not rushed for surgery. They are immediately intubated, because you should not try to ambu them, because the more you ambu them, the more it enters into the chest and causes more problem. So you immediately intubate
So
them.
Dr. Rawat, what are our immediate goals and targets as a pediatric critical care or a pediatrician?
Okay, the immediate target is first and foremost, the dictum is don't ambu this child. Put in an nasogastric tube to decompress the stomach, and very early intubation and ventilation. It has to be a gentle ventilation with permissive hypercapnia and allowing a reasonably amount of low PaO2, give them inotropic support, and then try to control their pulmonary hypertension by nitrous oxide or sildenafil, and at least for 20 to 40 hours, when the children are stabilized with a stable saturation, pulmonary pressures, and blood gas, then only say after 48 hours they are taken for surgery. In that case, the outcome is much better.
Shantanu, do you have to add anything?
No, just for the third question, when to consult a surgeon, I think surgeon should be consulted immediately, but intervention may wait for 48 hours to stabilize the baby. That's what I wanted to add.
Subhashish Da, so we have learned that this is a surgical condition, but this is one of the few surgical conditions which has to be medically managed first, and then surgery can be thought out of later. Definitely this child will need surgery. So Subhashish Da, when do you come into this picture and when do you decide to perform the surgery on this child?
Nowadays, actually, most of the children, babies, we see antenatally. So we along with our neonatologist, we are consulted antenatally. As a team, we assess the child, we decide the time of delivery, and once delivered, we see them together. So that's not an issue. The issue is that these children almost very invariably, they have a severe pulmonary hypertension. The degree of pulmonary hypertension may vary from one to another, but all of them have some degree of pulmonary hypertension.
Due to lung hypoplasia.
Yeah, because of lung hypoplasia. And so the basic thing is, the previous concept was, the moment you cure surgically, you cure the diaphragmatic hernia, lung will become normal. That's absolute rubbish. So basically, it's a lung hypoplasia that causes the diaphragmatic hernia, that doesn't cause lung growth. So there are a lot of antenatal maneuvers being treated. So there is a long story that you can clip the trachea, you can preserve some lung fluid that helps in lung growth and minimize the degree of distress in a baby. That is antenatal intervention. Now, postnatally, what we would like to stress upon is that these lungs are very, very delicate lungs. So even ventilating a baby with diaphragmatic hernia needs a lot of expertise. Particularly, one should not go, full-fledged, like pressure should be very low volume. You can give oscillatory ventilation so that the pressure on the tidal volume and this thing is very low. gentle ventilation. So even you may accept PaCO2 up to 40, up to higher, up to 50. So that is called permissive hypercapnia. So the basic idea is that lungs should not be damaged, and even you may you use medicines like bosentan, or you can use sildenafil or nitric oxide, or whatever is available with you. So the basic idea is once the baby is stable, there is a blood gas is satisfactory, only then we go for surgery. It's not 48 hours, it may be 24 hours, it may be 72 hours. So the bottom line is, and because there are babies nowadays where we refuse surgery, that's the baby cannot be, the pulmonary hypertension cannot be brought down. Incurable pulmonary hypertension. We had babies in the past, in last 2 years, that we did not do surgery at all because these babies cannot be saved. There's no point in going for surgery.
Subhash, inhaled nitric oxide has any role in pulmonary?
Yeah, of course, because this is one of the, there are two things which actually help in reducing this thing. That is, one is inhaled nitric oxide and one is sildenafil. And bosentan is actually PGE2 antagonist. So PGE2 is, sorry, not PGE2, that is phosphodiesterase, possibly inhibitor. So that is one factor that causes spasm of the pulmonary vessels, and prostacyclin as well as inhaled nitric oxide, they cause vasodilatation. So all these things help to minimize the pulmonary vascular resistance.
Is there any difference between a Bogdalek and a Morgagni hernia per se on a surgical table? No.
Yeah, the basic thing is, in Morgagni's hernia, these babies always present in childhood, never in neonatal stage.
So what do the symptoms you actually
symptoms have? It's usually recurrent cough and cold, sometimes pneumonia, apparently pneumonia, because there are haziness in the chest. So they are diagnosed as pneumonia. So always the basic tip is you have to do a lateral X-ray. So lateral X-ray will clearly show you the Morgagni's hernia is towards the anterior, just and retrosternal. And right. Surgically, it is much easier to repair it laparoscopically. And in diaphragmatic hernia, Bogdalek hernia, we do it either by open thoracotomy or by thoracoscopic. And Morgagni's is treated from the abdomen.
So may I come in for a second?
Yeah, please.
This is what bosentan basically is endothelin 1 receptor antagonist. This is number one, what Subhashish was saying. And I have a question to Dr. Saha. So do you see such a huge right-sided diaphragmatic hernia commonly? Because we see the larger diaphragmatic hernias on the left side. Is it equally seen on the both sides, or they have more?
Yeah, this was a picture of one of my patients actually. So incidentally, we were very, very scared. So this is a very scary picture. So antenatal, before surgery, we just told parents that we don't know exactly what to do. And because our experience with diaphragmatic hernia, right-sided, are very bad. I mean, most of them have survived, but there is actually very thin. There are no diaphragmatic rim. We always need a mesh. So these are the basic modifications for right side. But incidentally, this baby had an eventation. So it made things simpler, and this baby went home with just 2 days of ventilation. And so
this baby was having eventation.
Yeah, but we couldn't make it out before. So a lot of things are not obvious. So nobody could make out eventation with this X-ray. So, but on table we found that we always do in these cases right-sided.
How did the bowel come inside the lungs if it is eventation?
No,
it has gone up.
It has gone up. I mean, there is a huge sac. Eventation means it was completely like a paper thin sac. And that was, so here the liver is completely displaced. I mean, this looks absolutely like a diaphragmatic hernia, right-sided diaphragmatic hernia. But somehow or the other, the finding was it was eventation. But forgetting that, taking it to be a right-sided diaphragmatic hernia. Now, I tell you, the basic challenge in right-sided diaphragmatic hernia, that's a peculiar challenge, which is not present in left-sided is. Now, we surgically open at the, say, 5th or 6th space, right, posterolateral thoracotomy. We reduce the bowel contents. Then, while reducing the liver, anatomically, the hepatic vein is molded in such a way, developed in such a way that if you completely reduce the liver, then there will be a kink in the hepatic vein. That will cause an acute thrombosis and the child will die in moments. So the point is, in right-sided diaphragmatic hernia, often we have to be satisfied with less than adequate correction. So the liver will be slightly on the chest. I mean, all these things must be very clearly told the parents, and you need not be very scared seeing the X-ray on the next day that the right-sided liver will be a little up, because we have done complete correction and we have suffered.
So what is the kinking? How do you assess, by Doppler
On
or
table,
something like that?
on table. So we
Acha.
reduce the liver as much as possible, and we look for, we wait for some time. We look for the color change in the liver surface. So once we are happy that everything is fine, once the anesthetist tells us that all hemodynamic parameters are okay, then we do the repair. So it's just measuring on the table.
Just a notice for all the panelists, and Dr. Subhash is right. Dr. Rawat has most probably left. So he has given a message in the chat box that he is leaving.
Yes,
Yeah,
Subhash,
here's another
Subhash
Yeah.
Shaha, Dr.
Yeah.
Shaha,
Yeah.
is it the ultrasonography that can make out whether it's the eventration? You can see the diaphragm.
Not in this case, not in a newborn, not in a newborn. There is no such sensitive ultrasound.
Rather, a fluoroscopy is better. Subhash is the
Fluoroscopy is better. All these are in little younger children. I mean, in a neonate.
Yes, absolutely, absolutely. Not in this.
This particular diaphragm was so thin. I mean, it was not visible in any investigation.
Okay.
Now this one. Now this
Shantanuda, you see a strange shadow, gas-filled shadow in the left side of the lung.
Yes.
So, what is this? This is also diaphragmatic hernia. We can see guts and guts of intestine like this.
This is eventration, I think. This is
Why are you saying eventration?
This is the diaphragmatic border, or what?
Yes.
Yes.
So pediatricians always look for this sign. The diaphragm, actually, the diaphragmatic margin is being seen. So actually, the bowels are pushing the thin diaphragm upwards. So this is actually not lung shadow. And there is actually, Shantanuda, these children, are they so much distressed or having respiratory distress or symptomatic? I don't know. I have never seen a case of eventation.
Now, this was a baby actually. This baby was antenatally diagnosed.
Subhash is the patient.
Yeah. So this baby was also antenatally diagnosed and didn't have any much of a distress.
No, not much of a distress, because I think they are not associated with lung hyperplasia.
Yeah, exactly.
So our take-home point is actually how to differentiate clinically between eventration and diaphragmatic hernia. Is eventration is less symptomatic, is it, and less serious?
Yeah.
Okay.
That is true. But here also you find mediastinal shift. Mediastinal shift is there, and there was respiratory. I mean, tachypnea, etc., was there. But this child did not need, intubation, ventilation, all those stuff. So after birth, maybe had tachypnea, had grunting, all these things. But so here you can see the operative picture.
Yes.
Lungs are quite well. I mean, this is a thoracotomy on the left side, and you can see the lungs. Lungs look pretty good. So that's the difference.
Pretty good. Subhash is the what is
pretty good means pretty good means you can see the lungs. In a diaphragmatic hernia, there is small lobule-like lungs.
Looks healthy.
Yeah, looks healthy.
Okay. No. I just wanted to know, what does an unhealthy lung look to us? We don't.
Unhealthy look in diaphragmatic hernias. Lungs look very small, and even on bagging, it doesn't blow up. That's the basic thing.
Okay.
So much hyperplasia. Okay.
So eventration may require CPAP, but because I had this baby of a doctor actually, and the baby required CPAP for 6 weeks till 6 weeks of age. So eventration can have tachypnea and distress, but lesser than hernias actually.
So Subhash is the when do we intervene in an eventration?
Eventration actually is noted on. Now here a clear-cut sac is seen. A thinned out sac can be seen in this particular.
Suppose in this slide the eventration was up to this much. The child was asymptomatic. Would you?
No, nothing to be done. Nothing. There is no emergency indication for surgery.
No. Is there without an emergency indication? Do we need surgery in that child? Do we advise or let it be?
It depends. We have to assess. You keep on assessing how the lobes are inflated.
Okay.
So if both the lobes are inflated well, it's just a mild eventration, you need not treat.
Okay, fine. So all cases of eventration do not need surgery.
Absolutely.
So we go to the next stage. A 2-year-old presents with high fever and sudden respiratory distress. These slides are all from Subhash's great collection. So the child is tachypnea, saturation is 95% with oxygen by a nasal cannula. Breath sounds diminished in the right lower part, no mediation and stiff. Shantanuda, this is the X-ray. Could you please explain?
Okay. So high fever and sudden onset of respiratory distress. And what we can see is that there is a hyperlucency of lung and the mediastinal shift to the left side. Is that so?
Yes.
And breath, yes. And the breath sound
Even the cardiac
diminished.
shadow is shifted.
Cardiac, yeah. The total mediastinal shifting is there. That much we can say seeing the X-ray.
Okay, so what do you suspect in this? What are the differential diagnoses?
Again, some cystic disease. It may be lobar emphysema or hyper aeration of the alveolus, whatever is there, or pulmonary sequestration, or CPAP.
So,
C congenital airway pulmonary malformation. Some cystic diseases.
So what to do next? We do a CT scan.
CT scan. Here you see all the cystic-like appearances in the lung, and which can prompt that this is maybe a case of congenital pulmonary airway malformation where there is hematomas along with normal lung fields.
So for viewers, congenital pulmonary abnormal malformation is the newer term, the modern term. Initially, we used to call
Cystic
it cystic
adenoid
adenoid malformation. So Shantananda, why did the term change?
Because all the alveolar. Okay, you say. I can't say it properly.
No, because the basic thing was very simple. The histologists, the pathologists objected because they said there is no adenoma. Most of these cases did not have adenoma. So that's the
cysts are there.
Airway malformation. They said it is a cystic malformation of the airway. So it is.
Cysts are common, cartilages are less.
Previously, it was thought that all had adenoma, but adenoma was really common.
Yes. So Subhash, is how many histological types of there are in CPAM?
CPAM, there are now the Stocker classification. It has been modified. Now there are 5, type 0 to type 5.
0 to 4.
0 to 4,
and now there is also 1, 5. So basically,
0 to 4 is 5.
Yeah,
0 is
0 to
1,
4 is
0,
5. Yeah.
Yes, 0 to is 5. 0, 1, 2, 3, 4. So there are 5 types.
Yeah.
So which is the commonest type and the best type?
Best type is 1, where it's a bronchial malformation. So when it arises from the bronchus, the first division of the bronchus up to the first division, then it is good because there are no associated malformations. That is the basic thing. In type 2 onwards, there are associated malformations. That makes it worse.
And for EDS, it is type 1 is the commonest 60%. And we are always happy with macrocyst. We are not happy with microcyst. So it is mainly macrocystic version. So you have a large cyst or a large group of cysts.
More than 5 millimeter.
Yes.
And interestingly, there is one interesting feature here that microcystic lesions often present as solid lesion. They will present as solid SOL. You will feel even on CT scan, they might look as solid SOL, but they are microcystic lesions. Less than 2 centimeter, they are not often cystic.
So Subhash, in this case, 2-year-old child, we have made a diagnosis of CPAM, saturation is stable 95%. Do we need to go for surgery right now?
100%. We need to go for surgery because our dictum is we wait up to 1 year. That's the maximum amount of time we can wait because these children, like this child was lucky not to have an infection in 2 years of age, but up till 2 years of age. But most of the children, they have at least a very severe respiratory infection. They land up in the hospital in the middle of the night within the age of 8 to 9, 10 months. So if it's absolutely asymptomatic, between 6 months to 1 year, as per convenience of the parents, we go for a planned resection.
Also, all these hematomas are very liable to get sarcomatous or carcinomatous lesions.
That's in long term.
The important part. Yeah. This is the main difference between a congenital emphysema and a CPAM. Is CPAM, especially in type 4, in type 3 and type 4, there is a high chance of pleuropulmonary blastoma, which is a carcinoma. So our message would be congenital emphysema, you can just wait. But if it is a CPAM, don't wait. Do surgery at the earliest and always look for histopathological changes. So, Subhash, please explain. This is your case, huh?
Yeah. Can you go to the X-ray of this case, CPAM? X-ray, huh? If I say this is congenital lobar emphysema or
That's right.
clearly, how do you differentiate?
Now, here I think we cannot differentiate that much.
Now,
Only thing is
a simple statement here should be made. That is, nowadays we say that all these three, that is sequestration,
Yes.
congenital pulmonary airway malformation, and CLE, they are often they are hybrid lesions. So many of them are hybrid lesions. Now, many of the children with bronchial atresia and basically diagnosed bronchial atresia, we have patients with diagnosed bronchial atresia, but the remnant which was removed had CPAM-like picture on pathology. In full-fledged CPAM-like picture, when we did a resection, they found that CLE, there was a mixture of CLE also. So basically, it's a complete mix-up. Nowadays, all lesions are hybrid lesion, and unless things are improving very fast, and definitely improving, we have definite evidences of improvement, we normally go for a definitive treatment, at least by 1 year, if things are not resolved. Now, this particular X-ray on the left side, it shows a healed picture, same child. Now, we operated at 2 years. Now, this is 5 years. She's now 5 years old. And on the other side, it's a microcystic, as I was telling, microcystic CPAM. It appears as a solid lesion, solid SOL. This is another X-ray of another patient. This is not the same patient.
Oh, okay.
This is another patient.
So what Subhashish Shah was actually saying, these are all lung malformation at different embryonic ages. So they might have an overlap of features. They might have a mixed type of lesions also. So what our message is, always do an X-ray. If an X-ray you find a suspected lesion which you think that is a congenital, always go for CT scan. Don't skin CT scan. And we'll come to a later discussion that actually these cases has to be investigated much earlier, before they are born actually. So
and antenatal.
Shomik, I think you have to be fast because we are running short of time.
Acha. Subhash, is the role of fetal lung USG?
Fetal lung USG actually in our country it is in a very primitive stage. Now fetal lung USG actually tells us if both USG and MRI of mother fetal lung, that gives us an exact volumetry of the lung and all these. Now this is especially important where we are talking of antenatal treatment for congenital diaphragmatic hernia. In all the fetal centers where there is fetal surgery is done, so it's very important that MRI gives a exact picture. There are certain indications because not all diaphragmatic hernia babies are amenable for antenatal treatment because there is a lot of risk of premature labor and other things. So for all those parameters, it's very important. There's something called LH ratio, lung head ratio. So for all those things, ultrasound has a major role. Both MRI and ultrasound.
For all congenital lung lesion, fetal lung USG is very important, while CT is giving us more anatomical descriptions and MRI for vascular descriptions.
Yes, Amita,
CT should be avoided in mothers. During pregnancy, MRI is an ideal investigation.
No, definitely. Two things. One is for fetal diagnosis, USG is the diagnosis of SARS. And actually surgery, very little cases fetal surgery is done. So surgery is usually done postnatally. So that way, there you should do a CT scan of the baby because CT scan delineates the lesion, gives you the vascular features, everything. So CT scan is good for surgery. So Amita, you can stop us anytime if you see. So last case, 10-year-old child, sudden onset respiratory distress with fever and chest pain. Shantanuda?
Yeah. Here something there is no lung tissue is seen here in the AP.
So this is the X-ray, this is the CT scan. What do you suspect?
CT scan there is some other than lung tissue, maybe some sequestration or something, I don't know.
Okay. So Subhash is the follow?
So basically this child came with a completely white. This is a second X-ray. You can see the chest drains. That means it's a post-operative X-ray. So it was a completely white right lung when the child came to us. He was having high fever, respiratory distress, chest pain, cough for 2.5 months before it presented. And all the CT scan was done. That CT scan told us that it's basically complete consolidation and collapse of the right lower lobe as well as pleural fluid. So we did a video-assisted thoracoscopic decortication. And on our in front of us, and we were also thinking of a lung abscess, but we had given a 10 days of antibiotic therapy. So basically, when we did a thoracoscopy, we found that there were, of course, a collapse lower lobe with a lot of slough. So we did a complete slumpectomy, complete decortication. The lower lobe expanded fully, and we didn't find any area of lung abscess. So we put drain and came out, but this is the second X-ray. We have a CT scan, post-operative CT scan, which is clearly showing that it is an intralobar sequestration. So that was left behind. That caused a pneumonia and empyema, which we treated. So this needed a resection, lower lobe resection.
Did you do an MR angio, Subhashish?
Huh?
Have you done the MR angio?
We didn't do MR angio, but this particular child had a feeder from below the diaphragm, from the abdominal aorta. There was a feeder from abdominal aorta, but it was an intralobar sequestration. So there was also blood supply from the bronchial arteries. It had dual blood supply.
So Subhashish, do you go for surgery without doing an angiography of any kind?
MR angio can be done, but it's not essential. During surgery, we can find out if there is a blood supply from aberrant systemic artery, and we can tie it off.
Subhashish, there is any role of coil embolization?
Coil embolization doesn't make, it's an asymptomatic sequestration. Only in case of asymptomatic extralobar sequestration, it has been advised that if there is a feeder artery, it can be embolized and you need not do any surgery at all. That is a possibility.
Okay.
Small asymptomatic extralobar bronchopulmonary sequestration. Angioembolization is an option.
But intrapulmonary is more common.
Intrapulmonary, if it is very small, of course, but you cannot do angioembolization because it will be supplied by pulmonary artery.
So sequestration is basically a lung mass which has a vascular supply but has no role in aeration.
No role in that. No
gas exchange. Yes.
Ventilation.
Okay. Yes. So there is a ventilator perfusion mismatch as well. That is why these children become symptomatic and more infections. So last slide. This is a different case. Subhashish will take over and we'll stop it after that. Subhashish.
So this is a 16-year boy, suffered from a road traffic accident. We were called in the middle of the night with severe tachypnea, respiratory distress. So this was a picture. So we were discussing so long about diaphragmatic hernia. So this is not a congenital lesion. So it doesn't suit today's topic, but I just posted it just for in interest of the people. So that's a diaphragm was ruptured due to the road traffic accident. So that's how it looked. So the diaphragmatic edges have been refurbished and we repaired this thing. So these are all, that's it.
So thank you so much for giving me a patient hearing.
With permission of all, can Shomik share the screen with me for a case which I can show if time permits? Amita.
You have the screen.
We are out of time, I think.
Okay. Forget it.
9:48.
Thank you very much. I think. Thank you very much, everybody.
We have one line of summary from the moderator before we wrap up and say thank you to all. So if any of you could just summarize today's proceedings, any key take-home messages for all of us.
So congenital pulmonary lesions are not so rare as we think. They are usually often found at various ages with various presentations with like infection-like presentation, respiratory distress at birth, not taking up. So our key home messages would be, first of all, we should start practicing. It is in the West that a fetal USG of the lung should be done. Even in India, fetal USGs are done for now for maturation of lung purposes also. They have been done in some parts of India as well. One. Second is, whenever you find a an abnormal lesion in the X-ray, our presentation have showed is don't avoid a lateral X-ray first, and then if you find these suspected lesions persisting even in the lateral X-ray or giving you an idea, do not. We always are afraid of doing a CT scan, so radiation exposure. But in this case, even if it is a congenital pulmonary lesion, do not hesitate to do a CT scan of lung. It will give you more information, rather when you find some lesions like sequestration, Subhashish Roy will agree with me that you have to know the blood supply of the lesion. But according to us medical people, what we are, blood supply of lung is very important before doing a surgery, because the surgeon can see the blood supply as well, but he will be well informed. So there is a role of MRI angio as well in such lesions. And do not, some lesions may be counseled, but most of the lesions always for medical legal purposes do involve a pediatric surgeon or take his opinion before counseling the patients. If you both sit down and counsel the patients whenever you have this lesion, I think the parents will be more happy, satisfied, and both of you will be in the same line. If anybody else can add to this presentation, I would be happy.
It is a team approach, and don't forget to do a bronchoscopy in the upper part, as Pallav told. It helps in many ways to find out all the congenital lesions there, like laryngomalacia, trachea, and all.
I have two things to add to the summary. One is these emphysematous lesions. You don't, I mean, these can maybe just because of a foreign body aspiration in a little elder child. So that's one thing everyone should keep in mind. In a sudden onset emphysema, you always keep in mind that it could be a foreign body aspiration. That's number one. Number two is in diaphragmatic hernia, not all babies can be operated, should be operated. So there are very, very poor prognostic, as somebody has already mentioned in the chat box. There are very, very poor prognostic markers in cases of diaphragmatic hernia, which should be carefully noted, and the parents should be counseled that these babies won't survive even after surgery.
Yeah.
That's it. Thank you.
Yeah, I think it's been an excellent.
Just one question. Subhashish, amader CT te mediastinoscopy hoy?
CT te hai, virtual mediastinoscopy hoy to.
Hoy na?
Virtual bronchoscopy hoy, ha, mediastinoscopy. 3D reconstruction kora jay.
Okay, so should we now wrap up and say thank you to all who have joined today? Yes, a lot of knowledge sharing and a wonderful selection of cases, brilliant x-rays and scans. Thank you very much.
Thank you, everyone.
Thank you.